Let's talk about patient-reported outcomes. And what do you, you've been talking, so I'll give this one to Ben. From a clinician's point of view, what's your take on that, Ben?
Thank you. Firstly, can I say congratulations to CLL Support for 20 years. That's absolutely phenomenal. And to the next at least 20 and more. So well done, everyone, for that. When I did my media training many years ago, they said, look, when you're given a difficult question, just stick to your agenda. I don't think that's a difficult question. I think the time is right to, more than right, okay, to change how we do things and to examine ourselves in the clinic, what decisions we're taking and how we are taking them together. And Piers made this very valuable point about over to you. And I think this is something now where there is a duty and a responsibility by the CLL community in the wider sense to begin to redefine what success looks like and how best to achieve those outcomes. So it's not just about a bunch of clinician scientists determining on someone else's behalf what is the right thing for you. So we have to work out what those patient-reported outcomes are, but I'm not going to define those. So I think we need to have a conversation about what those outcomes really look like. We heard this morning from Anthea that life is about risk and benefit, but I do what is important to me. So what is important to us? And that is something that we need to reflect upon. So what is important? What do we want to get out of life, the universe, and everything? As a starter.
Well, that was clear.
I can be more disruptive than that.
Peter.
Thanks, John, and hi, everybody. So my story is slightly different to the ones we've heard. I was diagnosed at the age of 30, 23 years ago, so you can work out how old I am. Treatment naive is the phrase that's used. I've had no treatment. I've had no symptoms. I've been on watch and wait, active monitoring, and perhaps even beyond active monitoring in that period, and I actually don't have any checkups at the moment. But what I had was 23 years of anxiety, worry, fear. I had a young family when I was first diagnosed. My daughter was 18 months old. And of course, in those days, as Piers and George said, the treatment options were limited. There were chlorambucil was suggested, and stem cell transplant was suggested. Aside from that, there was nothing else. My doctor said to me at the time, the train is leaving the station and we need to make sure you're on it, which was quite a metaphor. I was fortunate after about 5 years of fear and anxiety, as I mentioned, to be made aware of the work that Terry Hamblin had been doing at Bournemouth and the gene mutation status. And with that information, I was in the mutated status, which gave me the positive, or more positive prognosis. We made some life decisions. So I had a son who's now 21, and we were able to carry on our lives as best we could, living through that anxiety. So when we talk about patient outcomes, for me, during that period, not having any treatment, being monitored with blood counts and other things, but for me, the measures were qualitative. What made the mountain worth the climb? And for me, it was my children. So in terms of outcomes, it's seeing my children grow up. It's one day perhaps becoming a grandfather, I don't know. I won't put any pressure on them. But for me, these are not quantitative measures. These are not blood counts. These are not the amount of time or the number of steps I do per day or the amount of green tea I drink. I've been through all of that. I've tried every herbal remedy, every exercise remedy you can think of. What made the difference for me was more of an internal perspective, to think about my beliefs, my behaviours, my mindset, and to challenge some of the assumptions that I had when you're given that very big word, leukemia. and how you carry it. So for me, it's qualitative, it's not measurable, it's about happiness, it's about love, it's about humour, and you can't put a number on those. So sorry, that's not a particularly helpful answer, but it's what I think.
So I'd now like to go to Pinky and look at it from what you've gained in your professional capacity with Support Act and the holistic manner, and what you pick up matters to people.
So when I was asked to do the web-based support for people with CLL, I wasn't, although my husband is a consultant who specializes in CLL, I really wasn't very familiar with CLL. And then I found out as researching and doing the Support Act that CLL is incurable, and at that point, that was what they said, it's incurable, and that the period of the active surveillance was very traumatic for a lot of people. And I thought that really lends itself well to the therapy that I do, which is ACT, Acceptance and Commitment Therapy. Because what acceptance and commitment therapy does is it focuses us, despite of the things that are going on for us, it focuses us to the things that are important to us, not on the things that are challenging or difficult. And I think what I have found is that with my work with the people of CLL, and I always advocate for people to help themselves if they have any illness. And I really love the whole philosophy of CLL. It's you're helping each other. You all have CLL and you're helping each other. And I've lost my train of thought now. All right, you're all helping each other. And and I find it very humbling because I actually learn a lot from you. And when I work with the people through the drop-in sessions or the one-to-one support that I do with the people who are the members of CLL, they have learned to, instead of focus on their CLL, is to go, okay, I've got CLL. I accept I have CLL. Maybe I'll have treatment. Maybe I have to wait for my treatment. Is to go beyond that and to go, but I have my life ahead of me. I still am able to do things. And I think that's renewed focus and renewed, it's always finding the things that are more important to them, more than their CLL, that I find that has helped a lot of people. I don't know if I've answered the question.
There is no, we are not going to come up with the right answer today, but we will debate. I know there are a number of carers here today, and Brian, if you don't mind me putting you on notice so you have a little minute to think about things, because Brian is very informed, and you've heard Sarah talk eloquently about Brian earlier. But from my own perspective, as a patient who's been in lots of treatment lines, stem cell transplant, FCR 1.5 times, and other combinations, I could tick most of the boxes that we saw today. To me, it's always been about quality of life. I agree entirely. Quality of life and the ability, and when you can't do something, it really gets at you. And I'm not talking about doing Land's End to John O'Groats. That's a different scale, and that was completely off the radar, so many times. But the likes of when your capacity is significantly compromised by virtue of the side effects of the treatment, or the fact that the treatment's not working. What I found most beneficial, and I think patient-reported outcomes and shared decision-making are in handshaking mode by virtue of I'm now on my third consultant. 2 have retired. 2 ward sisters have retired. So that's great. I love that statistic. That's my progression-free survival statistic. But having that relationship with your clinician, I started to see that ibrutinib wasn't working for me in the March, April of 2020 pandemic. And he said, not to worry, carry on. And I said, no, we don't know what's over the horizon. Vaccination was not mentioned really. And I said, I'm well at the moment. let's make that transition whilst I'm well and able to handle it. And it went very, very well. So that shared decision making empowered me to sort of determine patient-reported outcomes to a certain extent, if I can sort of weave a path through that. Brian, from a carer's perspective, and Brian has an encyclopedic knowledge. He is responsible for the authorship of our patient booklet and all of the material a lot of the material goes on our website. Brian has sourced and got verification for. So I'll come over and give you. You obviously can't say no to speaking now, Brian, by the way.
Well, thank you, John, for putting me on the spot. I really appreciate that. I'll get back to you at some point. It's a very difficult question, really. I think primarily the relationship that you have with your clinician is so vital, absolutely vital. We were fortunate enough to have Ben Kennedy as our clinician, and that made a huge difference. But the other point I'd like to make is that not only do people react differently to their CLL, but people are different anyway. They're different in their ability to understand, to appreciate, and in fact, to want to understand more deeply. And I do think it's a difficult job for the clinician to judge how far to go with each individual. I know people, because I talk to CLL patients all the time, I know people who just don't want to know what their future is. They just want to forget about it. I know other people who are so keen to know every single bit about the research that's going on and understand their condition. And I do think the job of the clinician is so difficult in that respect. But it does make a difference if you can appreciate the ability of the person with CLL and also the carer to understand what it is you're saying and what direction you're pointing them in. Some people will not need pointing, and some people will get upset if they're being pointed in a certain direction. But that degree of empathy, which I see in all the clinicians I meet, that empathy with the person with CLL, with the people sitting in front of you, is so absolutely vital. It really is. So please carry on.
Thank you, Brian. Forgive me, I'm not checking my social media. We have some questions in from people on Zoom. After FLAIR and before Celestial results, do we expect similar results for the newer BTKI, or would that be a presumption? Piers?
Thanks for that question. So those two studies are different in terms of how we give those combinations. And that's this MRD directed versus the fixed duration. So comparing those two is tricky for two reasons. One is the way we give the treatments, and two is obviously we're dealing with second generation agents. In the Celestial study, and the FLAIR study was done with the first generation agents. There are other studies using other agents given in similar manners, and we will learn more information about those combinations, probably really, in fact, I know very soon. I don't know the results, so I'm not trying to hide anything, but we will see results of other combinations of drugs with venetoclax, for example, acalabrutinib and venetoclax will be available probably in the next month or two, actually, because the results are already out as the indicator about results is already out as a press release by the company concerned, and it's going to be presented at the American Society meeting in December, and we get a preview of those results later on. In terms of MRD-directed therapy, because this is something that has become clear, that we've, for example, in the UK, have delivered a study which at the moment is not deliverable to patients out of the study criteria, despite the fact the drugs are actually available, and we could give that, and that's to do with licensing and reimbursements. But similar studies are being done. In fact, the German group have an arm which is very similar to FLAIR in one of their studies, and it's always a good idea to do things more than once, despite the fact people may not like that idea, because you want to make sure that it's a genuine result. So that's a very roundabout answer to say I think we will see similar results. I think the likelihood is things are either going to be the same in terms of the traditional success measures that we use, the outcome measures, or better would be my gut feeling about them. And which I think is why the whole point about the discussion about patient-reported outcomes and measures is important, because all the treatments we've got on offer at the moment, particularly in the frontline setting, are getting very, very good results. And that actually makes the decision about which one to give and matching that to the right patient even more important. And that's great news that we've got treatments which work really well, but we want to make sure we get it absolutely right. And that's why it's an important debate.
So is the, let's call it the standardization of patient-reported outcomes so that they're comparable, the responsibility of the clinicians to drive, the patients to drive, or is it something that we, our group, our STAR group, could get involved in?
I suspect it's for everybody, and the reason I say that is because if you mean by the clinicians, you mean the researchers in this context.
Yes.
If we don't do the studies, then we won't ever know. So we've got to do those things. It's got to be meaningful for patients, that actually what we say is something that's important. There's no point in us trying to measure something which in the end turns out not to be a relevant thing, both for getting people onto a study but also the outcome. But the third point is we all have to then go and persuade our regulators, and by that I mean the FDA, the EMA, the MHRA, that what we're measuring is valuable and is a reason to license a drug. Because if they don't license a way of giving a drug or a drug, then we can't get it. We're not allowed to prescribe it. And it won't be sold. And the company won't go for a marketing authorization and all the knock-on effects of that. And one of the problems we have is that regulators, I hope there are no regulators in the room, may not be in tune to what we think is important. And I'll give an example, less patient-reported outcome, but more this idea of MRD. The FDA do not want MRD reported outcomes, to be what we call a licensing criteria. So they won't license a drug on the basis of an MRD result. They say, well, it's not validated and it's not comparable. So there's been resistance from those regulators to actually say that if we report a better outcome in terms of MRD, for example, that is actually a meaningful outcome. So I think all of us have to work hard on this. It's a collective effort, and it does require it's a lot of hard work actually, because it's much easier to use things which are traditionally measured and we're all set up to do. And that's why it's important to have these discussions and then actually take that forward in a meaningful way.
Thank you. Time will be our enemy, but I'm conscious to try and balance the inputs we're getting. And we have a question from the floor. Sorry, can I read the question? And Ben has had a preview, so I'm going to hand over to Ben. Is the remit of CLL research to investigate how the immune system can be boosted? As I understand, in the disease, treatments and increasing age all mean the disease resistance is depleted.
Thanks, John. So CLL in some ways is an immunological disorder wrapped up in the context of a cancer. And I think that's something that we're understanding better as time goes by. it's very clear that as time goes by, immunoglobulin levels, that's our normal antibody levels, which we use to fight infection, simply decline in CLL. There's very little we can do about that. I mean, wouldn't it be great if we could take some kind of a supplement or something that brings those immunoglobulin levels back up again? But there isn't anything that we can really do to change that natural history. One of the problems with treatment is that, particularly when we were giving chemotherapy, is that there would be an incremental drop, a sudden cliff edge almost in immune competence and the immunoglobulin levels that we would see and the risk of infections that we would see. And that's something that some bits of it would recover, like some T-cell populations would improve after time, often after years. But they would never go back to where they were. So there was this business of the immune system dropping down, maybe stabilizing for a while, and then dropping down again with the next round of treatment, all on a background of a gradual sloping downward deterioration in immune competence. So the function of clinical research and clinical trials, to answer the question, is not so much can we boost the immune system, get it back up and running in some ways, as to how can we disrupt the natural history of the disease in total by keeping people as well as possible in every sense. Now, we've moved forward a long way in those overall supportive treatments. This is a supportive treatment. The changing nature of the doctor and patient relationship is a supportive treatment. The care and love and attention from friends and family is a supportive treatment. And the idea of prehabilitation and fitness and trying to be as well physiologically as we can is a supportive treatment. We heard about intravenous immunoglobulin and subcutaneous immunoglobulin treatment this morning. And I think it's a very important point that this isn't easy to access, but it can change both quality of life and reduce the frequency of infection for those people who are able to get it. But there are fairly strict criteria around how to access that. So not only do immunoglobulin levels need to be reduced, but we need also to show that prophylactic antibiotics may not be working as well as they should, and that the immunological, the dynamics of response to vaccines is also impaired. So there are several things, several elements that need to be well documented to be able to access immunoglobulin replacement. And that means things like keeping that diary, having those vaccines, asking about an specific immunoglobulin test to assess response to vaccines is very, very important. That documentation is part of that conversation coming back into the clinical realm to be able to access immunoglobulin replacement. So not everyone is eligible for that. So I think it's a difficulty that we can't always improve the immune system, but there are things that we can do to try and optimize our health.
Thank you for that comprehensive answer, Ben. We also have here in the room Dr. Samer Agrawal, who was our keynote speaker when we had this conference last year. And I'd like to just give Samer the opportunity to say a few words.
I did want to ask a question, because we started off with patient-reported outcomes, and two things I really picked up on. One, Peter's comment that in his opinion patient-reported outcomes were not measurable, and I think that's a really difficult for one as healthcare professionals. We like to measure things. I mean, let's face it, clinical research is a drug-based activity. And if you can't patent a drug for it, there may not be that much interest in it from certain parts of industry, in fact all of industry perhaps. Maybe I'm being a bit unfair. So I think that's a very important thing to bear in mind. Brian's comment that the empathy between yourselves as the people dealing with the problem or carers and the people looking after you is absolutely key. And it always strikes me as a bit of a shame. I suspect most people in the room, including all the healthcare professionals here, bar one, probably, or bar two, are not familiar with the published data that shows it's been documented in studies that empathic relationship at the very first time a doctor is meeting a patient dealing with CLL specifically has a huge impact on their quality of life and their psychological outcome going forward. What's not been shown, although I would wager a guess is probably relevant, is does that impact on clinical outcomes? Because we measure clinical outcomes. So I'm very mindful of the poster out there. So, there we go. So the things on this poster I think are really striking, and we do not teach these things. In medical education, we do not get this. And how to interact in a way that takes into account the feeling of the person in front of us. And you might find that surprising, but I'm afraid that is what it is. So if you're going to have cancer, this is a good one to have. Not helpful is the comment. Don't start with words, I'm so sorry, and gently but honestly be a caring and knowledgeable professional. So these are all really key things to get right for us as healthcare professionals. And the trouble is we can't easily measure them. But I think we need to be paying, I speak here as a doctor now, we really need to be paying a lot more attention to these factors, because I think they could be much more helpful than the excellent drugs we've already got. I mean, listening to Pierce, I would be thinking, wow, this is great. We've got lots of good treatments. So why don't, I mean, you can tell me, for the people in the, do you all feel that life is rosy? You may have this, but you're covered because we've got the drugs to support you and take care of you when you need to be.